Thank you, Kinga. If you see Kinga buried in her cell phone, it's okay because I'm holding her I Love Sages pin hostage until I see the confirmation message back, and then I'll be pleased to award her her I Love Sages pin. So it's a pleasure to kick off this session for the next 12 minutes, and we'll talk about the ethical and medical legal implications of surgical findings. So we start off all these sessions with a compliance statement, and these are very complicated because since we're talking about ethics and medical legal, I wanted to spend a little extra time on compliance and disclosure, and you can see all the pieces that go into this, but the, okay, we're dead. But the bottom line is I have no relevant disclosures to this, despite all the mechanics. All right, so here's the problem. Everybody wants an algorithm in life. People want a cookbook. They want a set of rules. I'm sure you've worked in a hospital where you're working with the nursing staff, and they want an algorithm that covers all the possibilities of different kinds of things. And you just say there is no algorithm. We're going to have to use judgment on a case-by-case basis. And you don't really want to be shooting from the hip, so you need a set of principles by which to make these kinds of judgments on. And so I'm going to bring really two big sets of principles to talk about today, and then sort of follow up with an issue on details. And these are very similar to the basic sets of human rights. As a former chair of Institutional Review Board, if anybody's done city training, anybody here do city training? A lot of people, you're going to recognize some of these principles. They often add justice and respect for as one of the main principles, Belmont Report, Declaration of Helsinki. But that's, we'll talk about the origins of some of these principles. But we're going to talk about beneficence and non-malfeasance, autonomy and respect for persons, and then sort of wind up with how the details do matter. So these concepts of beneficence and non-malfeasance are not exactly the same thing. Beneficence is to maximize the benefit to an individual or society while minimizing harm. That's beneficence. Non-malfeasance is that we should act in ways that do not cause harm to others, and not only in the strictest sense of the word should we not cause harm to others, we shouldn't even engage the risk of harm. So that's a really important concept when you're thinking about incidental findings, because the dilemma is to act or not act in each one of these situations. And so you need to benefit. How do you maximize the benefit? Sure, it would be good to take out something that looks like a cancer, but however, if it's going to be bloody and they bleed to death, that would certainly be a bad thing. And so these are the issues that we need to balance in order to succeed in these difficult situations. The related concept, a related principle, is the principle of PRIMUM non nocere. And this means, first, do no harm. So, as I researched this, I believe that you should bring this near and dear to your heart, but that does not mean you need to tattoo this on your back or your arm or your wrist in order to be a good doctor, although it's pretty handy on the wrist. If you're not sure what to do, you just look at your wrist and you go, oh, I shouldn't do any harm. So people have taken this to the extreme. I'm not sure what the motivations are to have this tattooed on your back, but I certainly applaud their sentiment nonetheless. There's a history behind this. Many people think that Hippocrates, this is Hippocrates, coined this phrase. Anybody think Hippocrates coined this phrase? One taker. The problem with that is Hippocrates wrote in Greek, and PRIMUM non nocere is Latin, so he got wiped off the board pretty quickly. It wasn't Galen either. It turns out that when you research this, I won't be able to give you a clear answer, but it's very clear that it postdates medieval times, and it's one of these two fellows, Thomas Sydenham or Thomas Ingham, that are both credited around the middle of the 18th century for the concept of, and putting it both in English language and in Latin. So in its current iteration of first do no harm, it's not that old. It's not that there aren't principles that date back to Hippocrates that are in some of his writings that are similar to this, but the actual quote is really not very old at all. What is autonomy? Autonomy is an extraordinarily important concept to surgeons. Autonomy is something that you should really ask yourself every day when you're consenting somebody for surgery, because this is a truly fundamental principle of surgery. And as surgeons, we should know everything there is to know about granting the patients the opportunity to have respect for their person and to be able to grant them the autonomy. It's very different than just saying you're free to make your own decision, because it means that we're obliged, absolutely obliged, to create the conditions necessary for a truly autonomous choice. So autonomy is very different than, here's a list of complications, sign it, read this and sign it. Autonomy is about creating the conditions so that they understand what the risks and benefits are, and that this becomes very important, because when you have an incidental finding and the patient's asleep, you have to really consider what would they want. That becomes critical. What is common, and what is historically common, and I think as a profession we're getting much better at, is the avoiding paternalism. We've all been in this situation where you get out, you get out your spiel, and the patient says to you, "Doc," whatever you say. And we've all been there. And that's, and it's tempting to say, "Hey, I say you should have a colectomy for $1,700. But we should be trying to do better than that. We should be trying to make them understand. So respect for persons and the avoidance of paternalism is going to be important even if they're asleep on the table, because it's not always going to be what we think they would want. We have to struggle to try to figure out what they might actually want when we find these things. The other related principle is what we all signed up for when we swore by the Hippocratic Oath when we graduated from medical school. This little diagram on the side of the screen shows the oldest recorded version of what's left of the Hippocratic Oath. So it's been around, obviously, for a long time. And if you go to the original version, as I let it roll on the screen, it talks about promising not to poison people and things like that, which seems pretty reasonable to me, but it's pretty long and involved, and very few schools actually ask their students to recite the classic Hippocratic Oath. So instead, there's a more modern version that we should be using these as guiding principles. So the more modern version was written by this guy, Louis Lasagna, in 1964, and he was the academic dean at Tufts University School of Medicine, and I had the privilege of being the chair of the IRB at Tufts University, and Louis Lasagna is a member of my IRB. Now, it's a pretty daunting task. Yes, it's great to be the chair of the IRB, but if you're sitting there with the guy that rewrote the Hippocratic Oath, and he raises his hand to speak, that's really impressive. And he was an amazingly thoughtful guy. I got to know Louis in his older years, extraordinarily articulate, even up to the time of his death. But not only did he rewrite the Hippocratic Oath, which takes just, I couldn't consider myself worthy to do it, to do a task such as this. But he's also the one that discovered the placebo effect. He was a pharmacologist, and so he's had just a remarkable career. And we would ask him questions like, if the cure for cancer was discovered, but the means of getting the answer was nefarious, what should we do? And he'd be one of the few people in the world that you would actually ask that question in all sincerity, and whatever he said, we would be fine with. So he wrote the Hippocratic Oath. It is something that is a little bit more manageable, something that most medical schools, not all, use, and he put it in terms that are stated in the modern day. And it talks about really respecting the patient, really working to not employ therapies that would be harmful, whether they're surgical or medical. And these are the things that we need to stop and pause when we come across the unexpected findings that our panel will talk about today. So credit Louis Lasagna, and it's a name you should put in your back of your mind for great history. Well, what happens if you break the oath? There's actually not a direct punishment if you break the Hippocratic Oath, but there are people who have written that this is really one of the essential tenets of malpractice, is failure to keep faith with the Hippocratic Oath, whatever version. The courts often actually refer to the classical version. And so when you go into the writings, and all the way down to things like Roe versus Wade, the original classical Hippocratic Oath is actually referenced in the writings of the Supreme Court. So we often stand there and we do it, and we often don't spend much of our lives thinking about it, but other people actually do. And it is literally true that one of the fundamental bases for malpractice is breaking faith with our Hippocratic Oath. So I'm going to end with just a couple of simple scenarios, not specific scenarios, of two things to sort of think about and to get you sort of warmed up for the rest of the speakers. And that is the incidental finding, but moving it back one. The incidental finding in the pre-op workup that's not directly related to the procedure. So here's a chest x-ray. And in case you're in the back of the room and you don't see the coin lesion, here's the coin. And to make it simple for everybody. And it's not uncommon to have a finding on an x-ray report as they pass our desk on these EMRs. We now have to click on everything going through. And I don't know about you, but I get a big stack of these and I'm in click mode. I just want to keep clicking. Anybody want to just keep clicking when they get these things? Yeah, absolutely. We all want to keep clicking. But that's not always the smartest thing we can do, since I'm talking about the medical and legal implications of incidental findings. The coin lesion is certainly incidental, but here's an example of what happened when everybody missed it. Massive lawsuit, massive opportunity to treat the woman's lung cancer, big time case in Brooklyn. And so not only are the incidental findings or things we're going to talk about in the OR and the video and the films, some of these are actually happened before, and we need to ponder those and we need to be responsible for those. It's really hard. The other type of incidental finding, and our panel is going to dwell on the cases, are what happens in the operating room when you find something and you're saying, well, I'm here and I need to deal with this. The first step is you have to know the data. The classic incidental operation of all time is the incidental appendectomy. For years and years and years, people said, well, you know, we're in there, we're going to take out the appendix, until the data showed up saying that there's no benefit for people over the age of 35. And there is no benefit unless the GI tract is open, because the risk of abscess actually outweighs the benefit of removing the appendix. You have to know the data, whether it's an appendix, whether it's an incidental adrenal lesion. You know, 2 centimeter smooth lesion in the adrenal is truly an incidental finding that you should follow unless it's metabolically active. If you find something in the operating room, you have to deal with the issue of consent. It's a particularly thorny problem if you get called to the operating room and it's not your patient. You know, the GYNs are operating, they reach up, they think they're doing us a favor, the gallbladder's full of stones, and they're only kind of sort of doing us a favor, because now we've got to deal with the thorny issue of consent. How do you deal with the issues around common bile duct injury? What about infection? What about the interplay between the original operation and this? How do you get consent? Now, in those times where, you know, it's happened in my practice, since I had a lot of referrals from the GYN service, I would not take out the gallbladder unless I could find the spouse and get it, and fill out a consent form and have a real consent discussion. Now, that takes time. But the idea that I would just remove the gallbladder because it seemed like a good idea, even in a gallbladder that was obviously not robin's egg blue that had disease, is unappealing to me from a basis of principles and medical legal risk. I would advise you to never, never assume that the patient would want what you would want. You may want your gallbladder out. Don't assume that they would want their gallbladder out, because there's plenty of people out there that heard terrible things from friends and neighbors about diarrhea or bile duct injury, and that you cannot assume that they would do it because you would do it. That's a huge trap and a massive mistake. If you have findings, it's common for me when I do lap choles and things like that, I swing the scope around and I find some unusual things in the pelvis. I try to replicate the old laparotomy from when we did open surgery. And, you know, we could be doing an appy or something even late at night. And rather than take something out, I would implore you to consider photography instead and come back and find another day. So these are the kinds of things you should be thinking about, and our speakers will show you this. So in summary, since I'm 30 seconds over, your actions should be based on principles, data, and risk-benefit analysis. In rare circumstances, you may not be able to get consent, but I would implore you to do two things. Number one, dictate the note yourself. Don't let a resident dictate a note when you're doing an operation that you don't have consent for. It's up to you to put your thoughts and the really good reasons why you're taking action on their behalf. Go find the family and talk to the patient immediately. In one of those cases where I got the husband's consent, the lady said, "I've had back pain for 20 years and all of a sudden it's gone today." And I'm going, "Thank you, God." And those are good things. And don't be afraid to look at the pre-op data and act on it. Don't assume that the PCP has read the report and is working up the coin lesion. Never assume that. That would be a huge mistake. And then finally, word to the wise, when you're in one of these dilemmas, don't ever be afraid to call your partners and get some advice and talk it over what the best plan is, so you don't talk yourself into something that seemed reasonable at the time and yet at the M&M really was obviously eminently stupid. So with that, I will turn it over to our panel, and thank you very much.